This is Dr. Karen Riley, family physician in St. George, Utah, and today I wanted to do a discussion about a recent video that I watched on Facebook by another provider that talked about how horrible medical records were, the electronic medical record was. And don't get me wrong, I understand where he's coming from. You know, most of the things that he discussed, I have had the same frustrations with myself. But I wanted to be clear about where we have come over time in using electronic medical records and how beneficial they really are. And disparaging electronic medical records in general is not really beneficial or helpful. What you really need to do is get to the heart of where the frustration comes from and why that is, why that's out there, why people are frustrated with using electronic medical records. So a big part of his criticism came about because he said it's a interference between the provider and the patient and having a conversation. And as someone who has been in both systems, I've used paper charts for years and years and years before transitioning to electronic medical records. I can tell you that there was always something that would come between the provider and the patient when you're trying to do documentation. In the past, typically, the way most exam rooms are set up, you would have a paper chart, and if it was someone who's had a lot of healthcare, it would be a very thick paper chart, and you would have this flipped open and trying to flip back and forth between sections on the paper chart and trying to hold your fingers in place and balance this medical record on your lap and try not to have all the papers falling out of it or the things that have been taped into the medical record like previous prescription refills or notes or other studies, and try not to have that whole record fall apart in your hands. Or if you were writing notes, the counter would usually be to the side and you would be turned off to the side taking notes and having your face or back partially to the patient. At least now with my laptop that I use in my office, I have it in front of me so I can type on my laptop documenting the medical record why I'm still facing directly with the patient and try to maintain as much eye contact with them above the top of the laptop screen as possible. So if you want to use that as your argument, I get it. I understand why when you're checking boxes and filling in things, you know, that can come between you and the patient. But there's always an art to medicine, and there always has been, about trying to keep that ongoing connectivity between you and the patient while you're trying to do what you need to do as a provider and documenting as well. Whether it's paper charts or whether it's electronic medical record system, it doesn't really matter. There's still going to be an art to that, and that's really up to you as a provider to find that happy medium and your comfort zone with that and trying to keep that ongoing communication dialogue going. But let me tell you what things are there in the medical record system that when I have paper charts didn't necessarily work. So number one, the electronic medical record is always there. I can log in on my computer or any terminal that has our medical record system on it and go right to the patient's chart and be able to find in the patient's chart what I need. Their progress notes, their labs, their documents, etc. When you had a paper medical record, I can't tell you how much time was spent in an office tracking down that paper chart. It might have been on another provider's office or on a medical assistant or nurse's desk. It might have been in the medical records department having papers getting posted into them, and so much waste of time just tracking down the chart in the first place. When we went initially to our first electronic medical record system in our office, we actually let go of one employee because that was how much of a reduction of human physical requirement there was in just trying to keep up with pasting stuff in a chart and chasing down medical records in the first place. So when I need a chart, it's there. I don't have to worry about trying to hunt it down, and the information is there. I don't have documents that have fallen out of the chart or that were taped in that got fallen, you know, or dropped out over the time. What is in the chart is always going to be in the chart. So that is one huge advantage with having an electronic medical record system, especially if you have a good one, over a paper chart. The next thing is portability. I can take my laptop computer and I can travel anywhere, and I usually do, and take it with me because I usually try to respond to patients' messages or prescription refills while I'm gone, primarily because I've been, for the large part of my career, in a small group or solo practice. And so if I'm traveling, I don't really have someone else to do that for me usually. And it's a little bit more efficient because I already know the patients, and it keeps me from being that much further behind in a pile of paperwork or work that needs to be done when I get back. So as long as I can have a secure internet connection, I can pull up that internet and get onto my electronic medical record system pretty much from anywhere and take care of those issues that need to be done. Try doing that with paper records. I mean, you wouldn't. You want to take the risk of those paper records being physically present in a suitcase or a book bag or a briefcase or something like that. The next thing is the records are kept longer. So what most patients don't realize is paper charts in the past had a life expectancy. And if you were an adult, your paper record was kept for 7 years, and anything past 7 years got purged. As a child, it's kept for 21 years of age. And once it's past 21 years of age, they can purge that as well, minus that 7-year statute that they still have to keep. So if you had medical procedures or stuff done, surgeries in the past, and it's been over 7 years and that was kept in a paper record system, good luck on finding that, because it's probably long gone. Nobody wants to store paper charts longer than they have to because it's expensive to continue to have those in a warehouse or storage unit somewhere and physically keep those records. When you have something in electronic record format, the likelihood of being able to track that down, even if you're not using that same record system, you usually move those records onto a new electronic record system or have a way to at least log in and access that data. And so you're going to be able to actually pull that information up when you need it, and it's going to be kept longer than those 7 years because you don't have to physically purge this bulk of records that you've been keeping in a storage facility or warehouse. Next is the searchability of medical records. So I did a video recently about the valsartan recall. In our office, we have been running registry reports to find all of our patients that are on valsartan to try to notify them that they need to change their prescription and that this has been recalled. And we can even do it through their portal by sending them a web message. Try doing that with a medical record. Would never have happened. You know what? The manpower it would require for a physician's office to go through every single patient's chart and try to figure out if that patient had been given a prescription for valsartan, it would never have happened. But because of the ability to use registry and searchable features in our medical records, we can find those patients that might need to be changed off a prescription or might need to have a certain medical study done. Or might need to come back in for a preventive health visit because we can search the registries. We're able to extract data. Again, if you had paper charts and you were trying to pull data from a paper chart, it was a manual process. You had to employ people to be able to go through those charts one by one, filter through the chart and find the data that you were looking for, and then you had to compile it into a database format or spreadsheet that was going to be usable. Versus I can do that right now from my electronic medical record on patients, whether for a specific patient or we're a group of the entire panel of patients. So for example, I can track data over time. If a patient wants to compare labs year over year, I can pull labs for a date range and have them printed out on one sheet, and they can look at their cholesterol for the last 3 years all on one sheet, instead of having a stack of papers of labs that I have to pull out of the chart, write down which each of those were, and give them to the patient. I can also do that for blood pressure, for their weights, for their hemoglobin A1Cs if they're diabetic, or their blood sugars, or an INR for patients who are on Coumadin. So that's a huge advantage in being able to track data over time for patients specifically. I can graph data. If someone has been concerned about what their weight has been and they're trying to lose weight, I can pull back as many years as I have of records for that patient and show them a linear representation of what their weights have been and how they have personally been doing on their weight loss. I can extract quality data. So we can try to reach target audiences on key factors. For example, hypertension patients. We can run a report on all of our patients who have a blood pressure over a certain level, and we can try to outreach to them more frequently to try to get them to be better controlled with their medications and try and get their blood pressures down, make sure that they're following up when they should be, or that they're following their blood pressure some other way, and giving us feedback to make sure that's being well controlled. I can do the same thing with diabetic patients. I can pull all my diabetic patients who have a hemoglobin A1C over a certain level, and we can try to have more engagement with them to try to get their A1Cs down. I can receive data directly into my medical record system from labs, from hospital systems, and from other providers. Now, the one limitation is that it is a little bit more expensive to be able to have that interconnectivity, to be able to do that. And not all providers are really embracing this idea of using their electronic record systems to the maximum ability that they could and having that interconnectivity together. But I do think this will continue to improve as time goes on. But hospital systems and labs, yes, they do. And so for me to be able to receive that data electronically directly into the chart and have that to be able to, again, track that data over time is invaluable. I can't express what a difference that is versus having paper charts and having to extract that data. So again, interoperability is not ideal, and that was one of the things that the other provider had mentioned in their Facebook video, and I agree with that completely. It is not ideal as far as the interoperability. He expressed some concerns over personal company reasons why they might do that, or personal health system reasons why they might do that, to try to have exclusivity of patients and patient panels, and maybe there is some of that is there. Another big part of it is that it's simply just the IT world and technology in general. I mean, let's face it, Apples don't really communicate with Windows-based platforms as well as they should, and vice versa. It is just what it is. And so you can't necessarily assume that all of that is a little bit of that paranoia of the exclusivity, although there might be some of that there. I won't disagree with that. But we need providers themselves to be able to embrace their record systems and using them to their full functionality. And I can tell you that, unfortunately, although a lot of clinics have adopted electronic record systems, they don't take it to that level. They don't go to using it to the maximum of its performance ability. Sometimes you need someone in the office who's going to spearhead that, and sometimes we don't always have the expertise or someone who has the technology ability to be able to man that and take us to that level in our office. If you look at the proponents for electronic health record systems, what they list as far as, main reasons why electronic health record systems are better than paper charts is they said overall clinical outcomes, so improving quality, reducing medical errors, organizational outcomes, so financial and operational benefits for health systems or hospital systems, societal outcomes, meaning improved ability to conduct research, improved population health, and reducing costs overall for society. That would be what all the healthcare regulation and reforms over the last number of years have been targeting, and why we've had that in the first place. However, they agree that despite these benefits, literatures have shown drawbacks to electronic health records, including high upfront acquisition costs. I can tell you I have spent a lot of money in getting on electronic record systems in the past. The current system I have is not nearly as expensive as the first system I had, but they're still expensive. However, we forget that when we have paper records, there's still a cost. You still have to buy paper on an ongoing basis, and ink and toner, and the charts and the chart pieces, and plus the whole manpower of trying to keep those charts put together. And when you take a look at that overall comprehensively, it's a trade-off. I mean, the cost that you spend on electronic record systems, on a good record system that doesn't have an exorbitant amount of maintenance costs, versus the cost that you would spend on paper and products that way, and manpower and trying to help just maintain those records, usually comes out to about the same. You're going to have that overhead cost one way or another. Ongoing maintenance costs, again, that depends on the company that you're using. Disruption to workflows. So as the provider had previously expressed his frustration as that interference between the provider and the patient, that is there. But sometimes there's other disruption to workflows that happen as well, such as things that we have to do for government regulation and the requirements for documentation that we are now required to be in compliance with. So there is that part of it that is in place there also. And that when you first go on an electronic record system, it does contribute to a temporary loss in productivity, and that is hands down, without a doubt. absolute. And that in itself translates to a financial loss as well. So anytime someone goes onto electronic record system, it's going to be expensive. It's not only going to be just the cost of the record system itself, it's also going to be the loss of productivity, which translates into loss of time and money on a clinic. Another problem is there is a perception of concerns over patients' privacy. We've seen in our technology world major corporations get hacked and have people break into their data systems, and unfortunately major health systems and medical record systems are not going to be immune to that. That is definitely a possibility, and that can happen. Versus someone's not going to get access to your paper chart unless they actually go break into the space physically, unless they're working in that office or have access to it that way. So I agree with the frustration of this physician in his talking about checking the boxes and trying to fill in all this data that we have to. But that's recognizing it for what it is. That's not the electronic medical record system itself that is causing the problem. It's what are we being asked to do with that electronic record system. So Centers for Medicaid and Medicare Services, the government, CMS, has us as providers jumping through hoops and compliance measures and issues with reporting. But this is something that we did to ourselves. I mean, that was a question that you asked me in video. How did we get here? Well, we got here because we did it to ourselves. We allowed it as providers to happen. As a political advocate in medicine, I was a alternate delegate from our Utah chapter of family physicians to the American Academy of Family Physicians for a number of years. And during the course of my participation, when I first started this, and this is many years ago, probably about 12 to 13 years ago when I first was participating with this, the first conference I went to at the national level, we were talking about pay for performance then. And you had physicians who were very passionate about, no, we can't allow this into our office. This is a downhill, slippery slope. Please don't go there. And you have other providers who are, well, I want to get paid for doing what I already do and providing great quality work. And yes, I get it. I see both sides of the story. But this has been going on for a long time. And again, this is because we have allowed this to happen. The first pilot program that I personally participated in regards to a pay for performance perspective, I guess you could call it, was the MCMP demonstration project. So Medicare Care Management Performance Demonstration Project. This was done between 2007 and 2010. This was targeting small and medium-sized primary care practices, and it was only done in 4 locations, 4 states. So Arkansas, California, Massachusetts, and Utah. And being a physician in Utah, I was part of that project. This was one of the first projects where it was a carrot. So if you were performing the quality metrics that they wanted you to demonstrate that you should be performing, you got rewarded for spending the time and reporting that you were doing that. Now, this was the first moment in my career where it was, aha, Big Brother is watching. And what I mean by that is the data that we presented back to Medicare, the majority of it they already had. They would send us pre-filled reports showing when patients had cholesterol profiles drawn, hemoglobin A1Cs drawn for their diabetes, when they filled prescriptions for statin medications or antiplatelet medications like Plavix, how they were compliant with those prescriptions, if they filled prescriptions for ACE inhibitor or ARB blood pressure medication in heart disease or diabetes. They already had the majority of this data. What they didn't have was, what was their A1C? Was their A1C below 9 or above 9? Because they had that the lab had been done, but they didn't have the results. And because this was a research study, we were allowed and required, if we participated, to present this information to the federal government. And so my staff would pull the data from our electronic record system and fill in the holes. But again, probably 75% of the data that we were required to comply with in reporting, they already had. They sent it to us in a pre-filled out report. We just filled in the holes. And I was quite successful in this pilot project because I was already doing the quality metrics anyway. They were tracking specific measures. So, for example, in coronary artery disease, did the patient have an antiplatelet medication? Were they on a statin? Were they on a beta blocker? Did they have a cholesterol level done? What was their cholesterol, LDL, bad cholesterol level? Were they on an ACE inhibitor or ARB? If they were diabetic, had they had A1C done? Was it below 9 or not? Was their blood pressure less than 140 over 80? Had they had a cholesterol level done? What was their bad LDL cholesterol level? Did they have urine protein measured? Had they had an eye exam done? Had they had a foot exam done? In heart failure patients, did they have left ventricular ejection function measured? Had they been given education on monitoring their heart failure with their fluid status and weight? Were they on a beta blocker, an ACE inhibitor, ARB? And if they had atrial fibrillation, were they on warfarin? And preventative care, did they have a blood pressure measured? Had they received a flu shot in the last year? Had they had breast cancer screening done, colon cancer screening done, or a pneumonia vaccine? So these are things that we should be doing as providers anyway, and this is back in 2007. We have been working on these same measures in compliance since 2007. If you look at meaningful use data, PQRS data, or PQRI, however you want to call it, and now it's MIPS and MACRA, all government compliance programs that we are required as providers to participate in, it is the same data. They have been tracking the same things for the last over 10 years. Why? Because we don't do a great job at keeping those things well controlled, and we have to bend the cost curve in medicine. And if we can work on targeting these specific high-risk conditions and maximizing the outcomes in these conditions in and of themselves, we would bend the cost curve of medicine, and we would see things change. Unfortunately, it's not always up to us as a provider. There is a bigger picture to that story, but when I first started working with the group here in Utah called Health Insight to help us capture our data and be able to get it reported, one of the auditors that worked with us in our clinic came in and talked to me. She said, I go into providers' offices and they don't even have a blood pressure recorded. How is that possible? In the year 2007, how is it that you as a primary care provider wouldn't have a blood pressure recorded? So you can see there's a huge disparity between the kind of care that we are providing in this country. And if that's the kind of care that is still being done, that needs to be fixed. And that is the reason why the government has now turned it from a carrot into a stick. Because they've tried the carrot approach multiple times over, and those providers who get it will get it, and they will adapt and they will capture that carrot because they can and because they're doing the work anyway. But you still didn't get those people who don't care. You still didn't get those people who weren't providing the quality that they should be doing. And so now the only way to get them to comply is with the stick approach. They're now saying if you don't do these things, if you don't live with your patients meeting up to this level of expectation of quality care, if you're not doing your part as a provider, we're going to beat you financially with a stick. And that stick is we're going to remove finances from you. Instead of paying the same level for your patients through Medicare that we have in the past, we're going to take monies back. You're not getting the same amount being paid for you because you're not providing quality care. And can you blame them? I mean, that makes sense. And we know that if we're going to make a difference, we're going to have to start somewhere. So I do understand the frustrations that this provider had in saying, we're checking the boxes and we're doing all this, but there's a reason behind that. I'm not a huge proponent of government interference and compliant measures, but I am a huge proponent of patient care and patient advocacy and doing the best care for our patients that we can and providing the optimal quality for them. And so I guess this is time for us, the providers, to wake up and step up to the plate and realize we need to do better. We can do better. We should do better. So electronic record systems, are getting the bad rap, but it's not their fault. It's not all about the electronic record system. You as a provider have to perform the art of medicine, but you as a provider also should be using those tools, which is what they are, just tools, to provide the best quality of care that you possibly can to your patients. And hopefully you'll get the bigger picture and you'll make that happen. And the fact is, until we continue to find a way to bend the cost curve and improve in key target demographics and disease processes, the government's not backing off. Not going to happen anytime soon. So you have to figure out how to work within the system, make it work to your advantage if you can. It's not going away anytime soon. It's either the carrot or the stick. So I hope this helps you have a greater understanding of electronic record systems in medicine, and how government involvement is acting in that. And I guarantee you, whether you realize it or not, the federal government and your insurance companies already have that data, and Big Brother is always watching. And so hopefully that's been enlightening for you. This is Dr. Karen Radley, a family physician in St. George, Utah. And until next time, Pura Vida.